Good evening, everybody. I will be deputising for Dr. Holohan this evening. He hopes to be back in work tomorrow, but as I'm sure you'll appreciate, we won't be making any further comment in relation to Dr. Holohan at this time. So this evening we're reporting 212 new cases, bringing the total number of cases to date to 3,447. We are also reporting an additional 14 deaths, bringing the total number of deaths to date to 85. Of the additional deaths, 7 are in males and 7 are in females, and the median age is 81 years. Again, I would like to take this opportunity to commiserate with the families and loved ones of all who have passed away as a result of COVID-19. We are also this evening reporting additional data on the 2,990 cases notified to the Health Protection Surveillance Centre as of midnight on Monday night. Amongst those cases, there was 134 clusters involving 563 people. The median age of the cases was 48 years, and there was a 50-50 split between males and females. 834 cases were hospitalised, and 126 had been admitted to intensive care. Community transmission amongst the cases stood at 60% as of Monday night. Now, as you will be aware, we are tracking public sentiment and public opinion in relation to COVID-19. And based on a survey of over 1,200 adults carried out on Monday night, we can confirm that whilst 9 out of 10 believe that the measures currently in place are appropriate, 1 in 3 are worried about their personal health, and 3 out of 4 people are worried about the health of their friends and families. However, the vast majority, 85% of people, are confident that they know what steps to take in the event that they themselves develop symptoms. 94% believe that they can adhere to the restrictions which are now in place, and 85% believe that they have adapted well to the changes brought about by COVID-19. Interestingly, 2/3 of people are now interacting with friends and family over the phone or through digital media, highlighting the fact that, as we've been saying, social and physical distancing does not have to equate with social isolation. In addition, it is clear that people are taking a number of steps to keep themselves well during this time, with popular activities reported including exercising regularly, getting outdoors where possible, reading and pursuing hobbies. So we're now happy to take any questions you might have. Thank you.
Aisling Nicush, the Virgin Media News. Could I just ask you, Doctor, obviously there's concerns out there about the length of time it's taking for people to get tested and get results back. Can you give us any further information in the shortage of equipment, in particular the reagents that An Taoiseach spoke about today?
Sure. So it's been well versed in public at this stage that we've had issues in relation to the testing process as a whole. And I might just take people through that process because I think there's some confusion about various elements of it. So in the first instance, when a person rings their GP, the GP decides, according to a case definition and a list of prioritisation criteria, whether the person should or should not be tested. If they're deemed that they should be tested, they're then given an appointment to attend a testing centre. And the HSE has stood up 45 testing centres across the country over the last number of weeks to facilitate that testing taking place. Following on then from having a swab taken, having a test taken, those swabs go to the laboratories and the laboratories obviously process the tests and then report them back out to the people. We've had various pinch points along the way. One which was well versed in public was around the availability of swabs to do the tests, and thankfully that has been addressed. And clearly, and as we've discussed in recent press conferences, there has been an issue in recent days in relation to the availability of reagent, which is the liquid that's used to process the tests in the laboratories. But in relation to the specifics around that and our plans in relation to that, I might hand over to Dr. de Gascon from the National Virus Reference Laboratory.
So, yes, as Ronan has said, there's been significant global issues really in the context of supplying of reagents, and in essence the primary issue at this stage is around the extraction of the virus RNA. So we've had a huge sort of upswell of support from various industry partners and universities, but unfortunately there's a certain amount of proprietary material that we need. So we're currently testing, I suppose, across the country in the region of sort of 1,500 tests a day, and at this point we had hoped to be up to 5,000, so we are somewhere behind on that. But it doesn't really change our strategy, which is to build up to a capacity of between 10 and 15,000 tests a day in a number of weeks' time. We're working with our existing partners to identify alternative options for the extraction process, and we've also got some new equipment coming on stream in the next probably 7 to 10 days.
I might also just come in there again. I think understandably there has been a persistent and understandable focus on testing and delays in testing. But I think, and I know we keep reiterating this, but the test is something that we're doing for the benefit of the population as a whole in the first instance, and it allows us to identify those who are positive first and foremost for the purposes of contact tracing. So a positive or negative test, a positive test or the existence of a positive test does not change the clinical management of an individual, but it does, or to date it has indicated to us who we should contact trace. But recognising that there are some issues around testing over this short time frame, and until we're able to ramp it up over the coming weeks, we are instituting an expanded contact tracing process. So over the next 48 hours, what we will be doing is instituting contact tracing for suspect cases. So once you're deemed suitable for a test, once you're given an appointment for a test, you'll also be followed up in terms of contact tracing so that your contacts are informed of any potential risk that might exist for them.
Good evening, Michelle Hennessy from the Journal.ie. If we can just come back to the issue of PPE, there are still questions from healthcare workers about why not everybody who's working in a hospital is being given some kind of protective equipment. In particular, yesterday, Professor John Crown raised the issue of healthcare workers who are working with vulnerable patients like cancer patients, and how staff in those areas would like to be able to protect both themselves and the patients who are very vulnerable. I know some hospitals have already implemented this. Is there a reason it's not being done across the board? Is that just because there is a shortage of this type of equipment?
Well, to start at the end first, we're fortunate we don't have a shortage now. We've secured the supply, as has been well. We've given notice of that, and those planes are landing now, and we're replenishing our depleted supplies, and we have a process put in place so we can deliver those supplies to the healthcare settings most in need of PPE, regardless of whether they're in the community or in hospital settings, and those that have the greatest number of patients and are running through their supplies as much as possible. The advice on the appropriate use of PPE is part of a broader range of advice given to healthcare workers to protect themselves and to reduce transmission of the virus. And that goes back to the basic message of personal hand washing and distancing and so on. And Martin Cormacan, who's our professor and leading up the AMRIC programme, a professor in microbiology, he's given specific advice which we review daily based on evolving evidence, and that looks at how PPE should be appropriately used and safely used, not just in terms of the settings and the situations, but also in terms of the training and the staff that need to use it, particularly in settings where they're in direct contact with patients with known COVID or suspected COVID. As regards differential advice or the practice from different hospitals, we're meeting daily with representatives from unions, with biologists. We're going through their concerns. We're reviewing existing advice as it evolves based on how the virus transmits both in symptomatic patients or before symptomatic. So our advice is not fixed. At this point in time, the advice we're giving is when you're not in contact with a COVID patient, wearing a mask may actually present some hazards instead of giving you protection. And that is because people may adjust their mask more frequently. It may distract them from the core practice of hand washing and other methods of protection that protect them from catching the virus and transmitting it. But as I said, this advice is constantly evolving and is responsive to the evidence as it evolves, as we become aware, not just here but in other countries. So we're not fixed, we're listening, and we're surveying the evidence. We want to protect our healthcare workers, and we want to stop transmission of this virus.
You spoke about the provision of PPE for workers in community settings. Mm-hmm. So does that include workers in care settings like nursing homes, where we're seeing a lot of cases? And when it comes to testing, are you now prioritising sampling with patients and staff at nursing homes?
Yeah, the first question first. Yes, outbreaks, we're seeing them in nursing home settings, in residential care settings, as well as hospitals. There's no difference in how we're going to distribute the PPE. We're giving it to the areas of greatest need, regardless of whether that's in the community or hospitals. The hospitals perhaps have more experience in the use of PPE, so there's an additional challenge in the training of some staff in nursing home settings over the use of PPE, which they might not be familiar with. And again, Martin Cormack and his team will be engaging directly with nursing homes and seeing how they can provide the best and most appropriate training in the most rapid possible way to all nursing homes. Sorry, the second part of your question was?
It was about prioritising testing for staff and patients in nursing homes.
Yes, we've already outlined how the challenges we face at the laboratory level in going through the tests, and how we're overcoming that in terms of going directly to contact tracing for priority groups. In terms of testing, we are prioritising healthcare staff in healthcare settings, again, irrespective of whether that's in a hospital or community.
Okay, and just another question on nursing homes. The Minister mentioned earlier on that there were isolation options that were being looked at for nursing homes. Can you maybe expand on that?
What we're doing is working very closely with HICRA, who are really very positive and supportive partners in all this process. So what we're doing is looking at the nursing homes where there are outbreaks, and with HICRA identifying those for whom they've already surveyed the relative risk in these nursing homes, be it the infrastructure or staffing or other elements of their regulatory process, and that matching and that risk will allow us to identify the nursing homes most at risk among where there are outbreaks. We can direct additional support staff, infection control staff, PPE and the other elements that will avoid transmission of the virus. Could I just add to that if I could? I know I could take the opportunity that it's important for us here to use this to emphasise the importance of healthcare workers, not just in terms of testing, but in terms of the transmission of the virus, because healthcare workers sometimes aren't confined to one setting. We know from the data you heard yesterday that, contrary to what people might have imagined, a minority of healthcare workers got the virus in terms of nosocomial infection or in healthcare settings. The majority are classified as community transmission, and this is an important message for us in halting the transmission of this virus, because we have to focus on behaviours of healthcare workers, not just at work but outside their living arrangements, how they relate to each other, because once they enter that healthcare setting, they're entering a new risk environment which is potentially much more hazardous than community transmission outside of a healthcare setting.
Just one last from me. Looking at the figures so far of positive cases, in the 55 to 64 group, it seems like there's a lower number of cases than the age groups on either side, basically, including the younger groups in some cases. Is there any indication of why that might be? Are there fewer of those people coming forward for tests?
So there's no indication of that in particular. I think it's important, whilst we're obviously, in terms of the Irish picture, we are talking about a significant number of cases in total to date. In global terms, we're still talking about a relatively small data pool. And so within that, there'll be variation, and there'll be maybe what appear to be unusual findings at the early stage of the outbreak. And I think, as we've said on numerous occasions, as the cases increase, the data becomes more robust. We begin to understand much more about how this is transmitting across our community as opposed to across communities in China or Italy or elsewhere. So hopefully over the coming weeks we'll be able to provide much more in-depth data in terms of age breakdown, gender, types of transmission and the risk factors associated with the disease in Ireland specifically.
Thank you.
Dr. Glynn, Shane Beattie from News Talk. Can I just ask you, the figures for confirmed cases each day are hovering at around 200, 300 for the past few days we've had them. People might find that encouraging at home because they're static enough. But is that because we're not carrying out enough tests? Is that the reason why, rather than people being encouraged by seeing 200, 300 confirmed cases a day?
So we've been very open that at present we're not carrying out as many tests as we would like to be, or as we had intended to be carrying out at this point. So in basic terms, if we were carrying out more tests, yes, we probably would be picking up more people. But equally, that doesn't mean that the picture in terms of hospitalizations or intensive care would be any different. And ultimately, from the perspective of tracking the disease and its impact on hospital capacity, they're the figures we're most interested in. As we ramp up testing, which we intend to do over a very short time frame, so over the next 10 days to 2 weeks, clearly we'll get a better picture of the burden of this disease on the population as a whole. But that doesn't change the management for an individual, and it doesn't change the decisions that are being taken either by NEFIT or by the HSE in relation to operational planning for how this will play out over the coming weeks and months.
You could just add, Shane, that Professor Ronan has taken, and his huge team that are inputting into this, do take into account undiagnosed cases. They do take into account any delays going through the testing pathway, but look at those acute indicators, namely the patients who are admitted to hospitals or other healthcare settings and those admitted to ITU settings. So that graph he showed you the other night is an amalgam, a synthesis, if you like, of multiple different indicators, not just the numbers positive, but also telling us his modelling ideas take into account other criteria too.
And just a final question for me on those undiagnosed cases. Are we keeping data of people who have died before the test result comes back as positive, for example? Or do we have any information on people who have died we suspect from COVID, but we don't have that confirmed?
So the data that we give in relation to deaths is based on anybody who dies, who had a test taken prior to death, and that test is confirmed as COVID-19 positive, whether that happens pre or post-mortem. So the figures will include anyone with a positive test who unfortunately subsequently passes away. Clearly, there's a time lag in notification of some deaths, and that's one of the reasons why we report 36 hours in arrears. So yes, to answer your question simply, all deaths are included in the figure that we give on a daily basis.
Perfect, thank you.
Dr. Glynn, just in terms of the ICU figure, there's been conflicting information we've been getting about what the total number of people currently in intensive care units is. From speaking to the HSE and from people in government, the figure was earlier on put at 124, whereas from what I understand from HPSE, the current or the total figure given for ICU is the total number of people admitted to intensive care since the start of the outbreak. What is the current number of people currently in ICU? Is there confusion over that figure?
So there's certainly no confusion about it. I think there may be confusion about who reports what figures. So we're obviously fully au fait with the current numbers in ICU at a given time, but they're operational matters, and that's not the purpose of this press conference. What we do, and again coming back to Shane's question earlier, our intention here is to present data that has a slight time lag on it, which is 36 hours, so that we can give the media and the population a more comprehensive overview of notifications and of data to date. We can't do that right up to the minute, but as I think again, as we've said, as our data systems around COVID improve, which they are doing rapidly, we will increasingly be able to give more and more comprehensive data and as close to real time as possible.
Could just add that in the HSE, we have real-time data on our acute beds and ITU beds, and we do that for operational reasons. We know site by site how many people are in each ITU unit, the number of occupied beds and unoccupied beds. We do that, as Rowan said, for operational reasons, for planning. And in normal times during a winter surge, for example, we may have to transfer people between hospitals. So that kind of data informs the way our everyday operation. But as I said, the purpose for what we're talking about today is how it helps us predict trends in the COVID-19 virus in our population. And the new number of admissions to ITU is one quite useful indicator in telling us how steep or how shallow that curve is.
So in terms of clusters then, what is the largest cluster you've found at this point? You've identified over 100 clusters. You were able to tell us a couple of weeks ago what the largest cluster was at that point. What's the largest cluster as of today?
I don't have that specific data here with me today, but what I can say is that the average number of people per cluster is less than 5. And so whilst we have a significant number of clusters, and obviously every single one of those is a concern, the vast majority of those clusters are not of a significant size. That's not to say that we're not concerned in particular about clusters in healthcare settings, in hospitals, residential care settings, and in fact they're precisely the reason why we took measures at NEFIT yesterday, and why, as Dr. Henry has said, we're moving to strengthen the resources that are in place for those settings over the coming days.
Is there any data on how long people are spending in intensive care during this outbreak? What's the sort of median?
So again, I suppose to refer back to my earlier answer, whilst we have a significant number of cases to date in terms of intensive care, in global terms or international terms, that's not a big figure. And so, and indeed many of the people who went into intensive care are still there. So it will be another week or two before we can really start to give detailed, comprehensive data specifically in relation to intensive care.
And just to add to that, you can only judge the average length of stay once somebody has been discharged from ITU. So that's important to emphasise the difference between the number of people in ITU who have been from those who have left. Then you get an evolving picture of the average length of time people spend in ITU, and clearly that's a much smaller number because the length of stay in ITU can be quite prolonged from international experience in this disease.
George Lee from RTE. Just a further clarification, if you don't mind, on those ICU numbers. And it relates to the fact that I listened to Dr. Catherine Motherway on radio about 2 days ago, and she had the figure for ICU that morning, which was consistent with the Health Protection Surveillance Centre number. But she also said, that I think it was 104 or 107 that day, and she said we also have 26 in ICU who we suspect have COVID-19 but haven't tested positive yet. So my question really is, are there more than 126 who are either, when you add in the suspected cases in ICU?
George, in real time, as I just referenced, we have for some years now in ITU settings keep a very real census from day to day and site by site and the number of people in ITU. And we've adjusted that census in recent times to accommodate COVID positive patients. The only way we can do this is in a binary way, to have those number of people who are COVID positive in ITU settings. Clearly at any one time there may be a number awaiting testing.
I think they had been tested, she described, but they hadn't come up positive, but they knew the classic signs of the cases so that they were considered to be COVID. But as you know, depending on where if the virus isn't in the nose or the throat, it mightn't show up positive, but it could be elsewhere. As
with any condition, it requires a confirmatory test. So COVID-19 is no different in that regard. But to emphasise, to address your question clearly, in the current context with the case definition, the bar is set very low for clinical suspicion. So you can rest assured, and anyone listening can rest assured that anybody who's clinically suspect, we're instigating full protection measures, full isolation measures insofar as we can, and protecting our staff and reducing transmission. But at any one time there will be a number of people who are suspect and will be tested, and clearly their tests we will fast track.
Are they included in the 126 that's here?
The figures we gave are confirmed cases.
Confirmed cases, okay, fair enough. And the other thing, in relation to those confirmed cases, I think it has been answered, they are all in ICU today. As such, they were the numbers. It's not like they include people who would have left, because the description here is admitted to ICU, which I think can cause some confusion, because somebody could be admitted 3 weeks ago and be gone. Is that figure the number who are currently in ICU?
No, that figure is the number in total that have been admitted to ICU to date.
Since the beginning?
Since the beginning.
So they're not all necessarily in ICU now?
Precisely, but given that we're talking about a relatively short time period since the beginning in healthcare terms, it's likely that the vast majority of those people are still in the ICU setting. As Dr. Henry said, internationally the experience is that people spend quite a bit of time in ICU. Okay. So no, the surveillance data that we give it intends to be comprehensive, but it's not up to the minute real time in terms of operational data.
Okay. And can I just ask you, in terms of today's number, which is 212, which is a good number compared to recent days, I'm just wondering how we should interpret that. Are you positive about that number? And I say that because we were 325, 295 the day before, and we were up to 294 and 302 some days before that. So we see this number of 212, and obviously there are questions, whatever, about the testing. Does that number make you confident? Is it a good number? Are you sure you're happy that that is reflecting something really positive? Because it looks, on a headline number, that it is. Is that the way you look at it? Are you happy that that number is reflecting a fall-off and in the number of cases, and probably a positive return from everybody's efforts to social distance and so on?
So I think there's a few elements to that. First of all, whether it's 100, 200, 300 or more, we're always conscious that every case is a person. So yes, 212 is better than 300 or 400. It's better than where we thought we would be. But I think, as Professor Philip Nolan said here on Monday night, we're only going to win this battle if we get the numbers right down. Ultimately, we have to stop each individual who has this transmitting it to one other person. There are a number of positive indicators that I think as a country we can take heart from, in terms of the total numbers to date versus what was predicted a couple of weeks ago, in terms of what we know from the population survey data in terms of adherence to the restrictions and people's willingness to comply. So we are hopeful that as a whole we're going in the right direction. The number of cases day on day has decreased significantly in percentage terms versus a couple of weeks ago. But again, I think it's too early to draw any firm conclusions, and certainly it's too early for myself or for anyone else to become complacent in relation to this. I don't think anything has changed about the magnitude of this or about the necessity for us as a population to approach this in as serious a way as we can.
Okay, it's a single number and should be seen as that rather than an indication of any new trend.
Exactly.
Okay, thank you very much.
Paul Cullen, the Irish Times. Can I just check? Last night it was said that only about a quarter of the cases among healthcare workers was nosocomial, I think, which I understand to mean between patient and stuff. And then if you leave aside the imported cases, that seems to suggest, does it not, a very high level of community transmission amongst healthcare workers specifically. Am I right in saying that? And if so, why do you think that is?
So it does suggest a high level of community transmission amongst healthcare workers. The precise reasons for that are, I would only be speculating at this point. I think, and I'm not going to do that, I think the figure we should focus on and be positive about in relative terms is that whilst we've been reporting that 25% of cases overall are in healthcare workers, what we reported last night is that just 6% of cases overall are in healthcare workers as a result of a transmission in a hospital setting. And that compares very favourably with international norms. In Spain it's 12%, in Italy it's estimated to be somewhere between 9 and 10%. So the precise reasons for the high levels of community transmission, it's difficult to know. What we do know, of course, is that healthcare workers, because of the nature of their work, have had to continue to go about their normal business on a day-to-day basis. So they may be coming into contact with people in a more general way than the rest of the population who we've asked to restrict movements and stay at home. But again, that's speculation, and I don't think it's helpful at this point.
And just remind me, if it's 6% for hospitals, what is it for nursing homes?
So that's 6% for it's nosocomial, so that would be 6% of healthcare workers have got it in a healthcare hospital setting, to include nursing homes.
Oh, right, okay. Can I ask you about, can you elaborate a bit on the change in the contact tracing, so that you're saying that suspect cases, before they're tested, are going to be contact traced? Presumably that's because there's capacity there, perhaps, that you didn't expect to have? Or maybe it's because of slowdown in testing?
Well, I think first and foremost, it's a recognition that we're not testing as many people as we would like to have been at this point. The HSE has very significantly ramped up its contact tracing capacities over the past number of weeks. So there are people there waiting and willing to engage in contact tracing. And so we're taking advantage of that capacity now and not waiting for a positive test. Of course, hopefully, we'll be able to look at that again in the next week or 2 weeks as testing capacity increases. But yes, basically, we are using capacity that's available to us to overcome the limitation in relation to testing at this what will hopefully be for a very short time period.
And when was that decision taken? Today, was it? Or?
That was taken at NEFIT yesterday.
Okay.
Just add, Paul, that we don't want to wait, that the delay in testing results delay the triggering of contact tracing, because that's essentially we progress with that now, and that's why we made that decision.
But that's different from, you're also contact tracing in the 2-day period pre-symptomatic, isn't it? That's different from what you said yesterday.
Sure.
In addition to, sorry.
Sure, that's in addition. So as more information has become available, it appears that it is a prudent measure to contact trace for the 48 hours prior to the onset of symptoms. That's not to say that there's very firm evidence at the moment around pre-symptomatic transmission. So, but but given the resource that's available to us, and that's completely in line with new ECDC guidance that came out yesterday, which suggested that you should be contact tracing for the 48 hours prior to the onset of symptoms. So that's what the HSE will be commencing.
And just finally about nursing homes. Have you issued any guidelines or advice to nursing homes? Obviously not about infection control or about PPE or anything like that, but about the management of seriously ill patients.
So I suppose just I'll let Dr. Henry come in a second, but there was a whole package of measures were recommended coming out of the National Public Health Emergency Team yesterday in relation to nursing homes, and that's about strengthened governance for the sector as a whole. It's about putting in regional teams around infection prevention and control and public health that can act as points of contact for people working in nursing homes who need support and advice. It's about engaging with the regulator, HICWA, who has obviously very good knowledge of the nursing homes to identify those most at risk in relation to COVID-19 and to put preparedness measures in place. It's about minimising staff movement across different nursing homes, so we don't want staff working in multiple different care settings at this time in particular. And as Dr. Henry said earlier, yes, it is about strengthening training for staff in those settings, and that's specifically around PPE, but of course it's around a whole range of issues that may come to light or may be of greater relevance over the coming weeks and months, so specifically around oxygen and end-of-life care. Dr. Henry?
Yeah, just as two elements, Paul. One is obviously the outbreak and the control of that and reduced transmission, and the other is the care. And they're parallel but overlapping at the same time. So clearly, what we want to do is enable the most care to be given for what is often a very frail population within that setting, and that will require not just the enablement and strengthening of public health measures to reduce transmission, but also the enablement of the staff there to deal with some clinical scenarios such as provision of end-of-life care or provision of oxygen care and provision of enhanced respiratory care with support from hospitals such as geriatricians and other hospital-based staff. So there are plans that we're putting together at the moment to give outreach support to some of these nursing homes where there are outbreaks. So
would patients be hospitalised then from the nursing home?
Clearly,
in what circumstances would that happen?
Clearly, it's I work as a geriatrician myself, and there are often circumstances where people who are in nursing homes have to be hospitalised for whatever reason, and it shouldn't be denied that. But in the context of a pandemic with a virus for which there's no immunity, and our strategy is to break that chain of transmission in all settings, our clear preference in terms of providing care is to provide as much care as possible in that setting, not just for the patient's sake, but to avoid admission to an acute hospital setting with all the risks that entails. So it's not a case that no people will be transferred to acute setting, but you're trying to enable the healthcare, the nursing home or the residential facility to provide as much care as possible to prevent the patient moving out into another healthcare setting.
And sorry for going on, but where a cluster is found in a nursing home and other patients and other residents show symptoms, will they be tested?
Sorry, could you repeat that question?
So you have a confirmed cluster in a nursing home,
yes,
but then other residents start showing symptoms. Will they be tested?
Absolutely, yes, they'll be tested. That said, again, highlighting the importance of the approach in terms of what we do versus what we do after we get a test result. If there's a confirmed case in a nursing home, or if there's a cluster in a nursing home and other patients have symptoms, we don't wait for the result of those tests to take action. There's an outbreak control team that's put in place immediately to control the cluster, and patients with symptoms, in as much as possible, will be cohorted to prevent spread to those who don't have symptoms or those who are deemed not to have COVID-19. So yes, the testing will be done, but the testing does not dictate the management.